Welcome to our podcast, Heart Failure Morning Commute, Managing Patients with Mid-Range or Preserved Ejection Fraction. Morning Commute is developed in collaboration with At Point of Care and Projects and Knowledge and is part of a continuing medical education series. This independent CME-CE activity is supported by independent educational grants from Boehringer Ingelheim Pharmaceuticals Incorporated and Eli Lilly and Company, and from Merck Sharp and Dohme Corporation. In this episode, Dr. Deepak Bhatt and Dr. Javed Butler take a look at current guidelines for managing patients with heart failure, the sometimes confusing heart failure labels, as well as foundational therapies. Information about the faculty and disclosures can be found at morningcommutepodcast.com/heartfailure2. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Bhatt is Executive Director of Interventional Cardiovascular Programs, Brigham and Women's Hospital Heart and Vascular Center, and a Professor of Medicine at Harvard Medical School, Boston. Dr. Butler is Professor of Medicine in the Department of Medicine at the University of Mississippi-Jackson. I am Candace Hoffman, Managing Editor of Morning Commute. Dr. Bhatt will begin our discussion.
Welcome to our second podcast. Javed, welcome back. It's great to have you again. So let's take a closer look at the patient who is diagnosed with heart failure and the current guidelines on how to manage them. So maybe, Javed, a good place to start is with guidelines. And I guess since we're in the US, we can start off with the American College of Cardiology, American Heart Association guidelines, although those haven't been updated as of the time, at least of our discussion, to reflect the absolute latest clinical findings, although there are new guidelines that have come out of, say, Europe. The European Society of Cardiology released their heart failure guidelines this past summer, and I must say I thought those were really quite good. So any thoughts about the guidelines?
Yeah, guidelines are sort of really important. Our erudite colleagues, a lot of them put a lot of thoughts into them. And the last set of full guidelines from the American College of Cardiology, American Heart Association, and Heart Failure Society of America was almost like 9 years ago. They have been a couple of focused updates. So we are really all sort of awaiting the guidelines and see what they say. As you mentioned, European guidelines recently came out, Canadian, Japanese guidelines came out. So we have a little bit of a sense of which direction our international colleagues are thinking about guidelines. But there's a lot of data that has come out that we can at least opine on what the ACCHA, HFSA guidelines might say, but we just don't know yet.
Yeah, I think that is a good, it's hard to speculate what will be in the guidelines. As far as the US guidelines, it's actually a pretty long hiatus for the guidelines, but the European guidelines I thought were terrific, and just because it says Europe in it doesn't mean that we can't use them in the US. Again, I thought they were very thoughtful, very evidence-based, very nice color coding. So for anyone in the audience that really wants to come up to speed quickly on what's newest in heart failure, I would say look at those European Society of Cardiology heart failure guidelines. Anything from those guidelines that you thought was particularly interesting or would like to highlight, John?
Yeah, many things, So obviously there was a lot written about heart failure with reduced ejection fraction. So we'll keep that for a later time. But focusing on heart failure with mid-range and preserved ejection fraction, there was a big change, because if you look at the classic guidelines, both in US and in Europe, for management of patients with heart failure and preserved ejection fraction, it was basically the top line was that there are no therapies that have been shown to improve outcomes. So basically, it was symptomatic management with diuretics and congestion. So the guidelines in US and in Europe basically was focused on symptomatic improvement, giving diuretics for congestion, and for the patients to have their comorbidities managed, whether it's cardiovascular comorbidities like atrial fibrillation or ischemia, or non-cardiovascular comorbidities, diabetes or chronic kidney disease. So that was the focus. Now, what's interesting is that we have a lot of data from clinical trials, the past clinical trials, that did not meet their overall primary endpoint. But if you look at the subgroup analyses of those trials, it turns out that this group of mildly reduced or mid-range ejection fraction, or heart failure with MREF, if you may, those patients actually act very much like heart failure with reduced ejection fraction. So there are meta-analyses with beta blockers that group benefits. CHARM trial, that group's benefit. We saw that with TopCat and MRAs. So there's a lot of data. So actually the guidelines now specifically give a class 2 recommendation for the same therapy that we give for heart failure with reduced ejection fraction to patients with heart failure with mildly reduced ejection fraction as well. So all the way up to 50. Now, why do we give a class 2 recommendation and not a class 1 recommendation? So for our colleagues who don't live and breathe guidelines all the time, class 1 recommendation is a good idea, do it. Class 3 recommendation is a bad idea, don't do it. And class 2 is sort of a strong suggestion, but not to the same level as class 1. And the reason is that these recommendations are based on subgroup analyses of other trials, as opposed to the HFrEF trials, which were just focused and powered entirely for heart failure with reduced ejection fraction. So I think the biggest thing that they have done is to give the same recommendation. Having said that, the first trial ever to be positive in patients with HFpEF was actually presented the day when these guidelines came out. So those were not, those data did not inform these guidelines, so we can sort of have our own opinion about which way things should go.
Great. So before getting to some of the newer data and newer therapies, maybe we can discuss some of the older therapies, such as ACE inhibitors, angiotensin receptor blockers, beta blockers, mineralocorticoid receptor antagonists, really the foundation of treatment for heart failure, certainly heart failure with reduced ejection fraction, but as you said, also those with mildly reduced ejection fraction. Any thoughts about those data sets, which now are largely older data sets?
Yeah, so the CHARM trial, regardless of the EF, actually did meet the hospitalization reduction endpoint. It was not the primary endpoint, but on the basis of that, there was already a class 2 recommendation, even in the previous set of guidelines with candesartan. So with ARB, you have that benefit. There's a meta-analysis of all the studies, both observational and randomized, to look at beta blockers at the higher end of ejection fraction. They show benefit. And then the MRA trial, again, lots of controversy for the TopCat trial with patients that were enrolled outside of North America, may not have actually heart failure or may not have received the drug. But if you exclude those patients and focus on the 2/3 of the patient enrolled in the North Americas, there was a substantial benefit in that group as well. Now, the good thing is that there are 3 other trials going on with MRAs and HFpEF. So we'll get to the truth. But I think for the time being, the classic medication, candesartan, beta blockers, and MRA, all of them have shown benefit. Then you have the valsartan sacubitril, Paradigm HF, big benefit in heart failure with reduced ejection fraction. But there was a trial done called Paragon in heart failure with preserved ejection fraction. And it turns out that the median ejection fraction in that trial was 57. And those people that had less than median ejection fraction, so a little bit more than what we are calling mildly reduced EF, so say 40 to 55%, they also had a significant benefit, but the higher EF patients did not benefit. So I think at this point, either an ARNI or ARB, beta blocker, and MRA is pretty much the standard of care for patients with EF of less than 50%. And I think that we should include definitely Sglt2 inhibitors in that category as well. The reason why they are not in the European guidelines is because those data were not available when the guidelines were being written.
Yeah, that's a really important point because there are data now for Sglt2 inhibitors in these sorts of patients. And at least at the time we're speaking, that's not a labeled indication, but I imagine that it will be sometime, in the next several months or so. So the Sglt2 inhibitors, I think many people in our audience might still think of them as diabetes drugs, but in fact, well, they're great diabetes drugs, but they're also drugs for heart failure, as it turns out. We'll get into that class of drugs a bit more later on, but what about GLP-1 receptor agonists, which are diabetes drugs for sure? Do they have any role in these patients that we're talking about with heart failure with preserved ejection fraction or mildly reduced ejection fraction?
Yeah, so with GLP-1 receptor agonist, life is a little bit more complicated than Sglt2 inhibitors, where there is a consistent signal of benefit in prevention of heart failure and treatment of heart failure. With GLP-1 receptor agonist, if you look at meta-analyses of all the type 2 diabetes trial with GLP-1 receptor agonist, there's a softer signal that actually does reach statistical significance, but about a 9% reduction of new onset heart failure. So as opposed to SGLT2 inhibitors, which is about a 30% relative risk reduction. But that's in type 2 diabetes. But what about the use in those who already have manifest heart failure? So I am very, very optimistic about the use of GLP-1 receptor agonist in heart failure with preserved ejection fraction. And if I were a betting man, I would say that they will confer benefit because of their significant effect on adiposity. And adiposity has such an incremental role, such a sort of important role in development and progression of heart failure with preserved ejection fraction. And adipose tissue is pretty much a factory for inflammation and oxidative stress that it makes a lot of sense. So there are 3 trials ongoing in HFpEF. I don't have any data. They are going on both in patients with and without diabetes who have HFpEF. So we have to wait. Now, HFrEF is a little bit more of a tricky issue because GLP-1 receptor agonists are associated with some increase in cyclic AMP levels intracellularly, a little bit increase in heart rate. And these things classically in HFrEF have not been beneficial for the patient. And in fact, there is some harm associated with that. There are 2 small studies that have been done with GLP-1 receptor agonist and heart failure with reduced ejection fraction, the FIGHT trial and the LIFE trial. Both of them, woefully small to make any confirmatory decisions whether these drugs are safe or unsafe or whether there is any benefit. But nevertheless, in both those trials, the directionality for the primary endpoint, cardiovascular, not the primary endpoint, but the clinical endpoint of cardiovascular death, heart failure hospitalization, was actually going in the wrong direction. So with that biology of CAMP, heart rate, with these 2 trials showing the data going in the wrong direction, my bias would be that if you have somebody with HFpEF and you're giving GLP-1 receptor agonist for type 2 diabetes, sure, go ahead. And you're likely going to benefit HFpEF, but I don't know. We'll get the data for HFpEF soon enough. If you're giving it to a non-heart failure patient, sure, you can expect some benefit for heart failure prevention. But if you truly have HFrEF, today, I would probably try other drugs. And let's look at some large observational studies to see what's going on there.
I think that's really a great summary of a lot of data with respect to GLP-1 receptor agonists. I mean, these are terrific diabetes drugs. And for that matter, they also appear to be great obesity drugs. And the number of trials and areas you mentioned, and just in obesity as well, are just really a number of high quality, well-powered trials. So we're really going to learn the answer. I certainly think in patients that are very overweight and have HFpEF, a proportion of that is due to their obese state, and a GLP-1 receptor agonist there, I would imagine, could have particularly large benefits. So I really, much like you, I'm eagerly awaiting the ongoing trials. So perhaps now we can move a little bit from data to talk about heart failure labels. It sometimes is a confusing topic, what is labeled for what. I think physicians are sort of aware of labels, but maybe don't always know what labels are. Do you have any thoughts about that and how that should impact the care of patients with heart failure? In particular, again, we're talking in this segment about heart failure with mildly reduced or mid-range or preserved ejection fraction.
Yeah, so there's a little bit of a tension to be very evidence-based, but that evidence base is based a little bit on historical construct and not necessarily sort of biologic construct. So I can give you my opinion, but I want to be sort of explicitly transparent that this is my opinion and not necessarily that everybody will agree with it, or perhaps maybe the guidelines are not going to say that. But if you truly look at what the labels are right now, then 40% or less is HFrEF, 41 to 49 is heart failure with mildly reduced ejection fraction, and 50 plus is heart failure with preserved ejection fraction. And then if you used to have EF less than 40%, but now it has improved, then it's heart failure with improved ejection fraction. And if you're sort of completely recovered, there is a sense that if you stop the medication, things tend to get worse. So it's labeled as heart failure in remission, if you may, sort of taking the analogy from the cancer world. So that's what the classification is. The problem that I have is that, one, sometimes it becomes a little bit too difficult to digest in the primary care setting. Our colleagues who are not only worried about cardiovascular diseases, but are treating a lot of different diseases, that's one. And then two, our therapies don't line up exactly with these definitions, right? So we talked about valsartan, sacubitril showing benefit all the way up to EF 57%, for instance. And then, same thing with top tetrol and MRAs as well. So maybe we can have these nuanced erudite classifications for scientific purposes in the background, but in the front for the patients, I would think that it's probably pretty reasonable to dichotomize it at 55%. And if you're less than 55%, just treat it like HFrEF and give all the 4 drugs. And if it's more than 55% today, give Sglt2 inhibitors and diuretics, and let's see what the other data show.
Yeah, I just really agree with 100% of what you said and have nothing more to add there. A term that's used in some circles, at least increasingly in cardiology and in heart failure cardiology, is the term foundational therapy or foundational therapies. Do you want to talk to the audience a bit about what is meant by foundational therapies in the context of heart failure? You sort of alluded to it by not calling it that, but what is meant when someone says foundational therapies? This patient should be on foundational therapies. What exactly is the foundation?
Yeah, so the term that we used to use, and we still use them, is called GDMT, or Guideline Drive Medical Therapy, except that the Guideline Drive Medical Therapy is very nuanced and has layers to it. So there are certain therapies you give to sort of all the patients in the absence of intolerance or contraindication. And then based on the response to those therapies, then you give, some specific therapies to one group of patients, say perhaps whose heart rate is persistently high, other therapies who have some specific abnormalities like, say, iron deficiency and all that kind of stuff. So there are sort of layers to the guideline drive medical therapy. But foundational therapy are those therapies that are at the bottom, at the base, as the term applies. It's a foundation. So all patients should get these therapies unless and until there's a contraindication or if you're intolerant. So the foundational therapy, the term is primarily used in heart failure with reduced ejection fraction with the 4 drugs, RAS inhibitor, beta blocker, MRA, and Sglt2 inhibitor. But I can bet you that we're evolving at a point that we will be using this foundational therapy concept in higher ejection fraction related heart failure as well.
I think that's a great explanation. And in terms of the foundational therapies, I think historically it's sort of been start one, see how the patient does, maybe titrate up the dose at the next visit, and add number 2, see how the patient does, and so on, so that by the time you get to the full foundation, maybe the house has collapsed. That is, it just takes a long time. What's the latest thinking, in your particular thinking, about the sequencing, which comes first, how quickly should it be done?
Yeah. So there's a lot hidden here, and I'm sure in one of the subsequent podcasts we'll really dig deep into that. But the high level sort of concept here is that we only have so much money to spend, right? So you cannot sort of spend full on everything. So what do you do? So your spending function of your creatinine and blood pressure and heart rate is only so much. So the general sense is to not give one therapy at such high doses, still indicated doses, but higher doses, that you run out of your blood pressure or creatinine or potassium or something like that you cannot give the other therapy. So the idea right now is a little bit against this concept of sequencing and give this drug first and that drug later, but actually match it to the person sitting in front of you, depending on their dizziness or blood pressure or what, heart rate or atrial fibrillation or creatinine. And whichever drug you start first is fine. Just don't take too long and just put them on all the 4 drugs in the next 3-4 weeks as soon as possible as you can.
Yeah, that's really great advice. Well, it's been a fascinating conversation with you. We've covered a lot of different ground about heart failure with mildly reduced. Sometimes it used to be called mid-range. And then also a heart failure with preserved ejection fraction, but also touching upon heart failure with reduced ejection fraction because there is some commonality in terms of at least some of the drugs that are used. So just for our audience then, I want to alert you to our next podcast, and there we'll be discussing heart failure in the patient with type 2 diabetes and other cardiovascular risk factors. Even in this segment, we touched upon some drugs such as Sglt2 inhibitors that are drugs for diabetes, but separate from that, they're also drugs for heart failure. And of course, in someone that has both diabetes and heart failure, they're particularly apt drugs to use. But we also touched upon GLP-1 receptor agonists, and there it's not so clear that they have a role in heart failure with reduced ejection fraction, but they do seem promising in heart failure with preserved ejection fraction, in particular in patients who got obesity, with a number of trials that are ongoing with that particular class of medicine. So we'll discuss this and more in our next podcast. So please make sure to tune in for that one. Thank you.
Thank you for joining us today. Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/heart failure 2. Look for all of our podcasts on your favorite podcast streaming services.